I am Cheryl Suhr. I'm a nurse practitioner with Raise the Bottom. I just want to clarify something really quick. I haven't actually given this presentation before. That's okay. I just had a meet and greet with some people from Pocatello who asked a lot of questions, and the conversation could have gone on for hours. So that was the question and answer piece about opioid treatment programs. So just for clarification. Okay, great. I guess I can start now, huh? All right. So you can go to the next slide. I put this introduction on here because I really didn't know where to start with this. Methadone clinic is a very common term that is used interchangeably through many different walks of life and people. And we're actually opioid treatment programs. And I just wanted to give a little scenario about where I started in opioid treatment programs. And I initially thought it was just a methadone clinic. I was a nurse. It was 14 years ago, or almost 14 years ago. And I just came in on weekends to support the weekly staff and gave them a break, and I gave medication. And at the time, we were just giving methadone daily dosing from the windows, but we also have, our medical director was also prescribing Suboxone as well, or buprenorphine products. And I didn't know that until I continued to work for Raise the Bottom and get greater experience with opioid treatment programs, and the fact that they actually, we can offer methadone, buprenorphine products, and naltrexone. So it's much more than just methadone clinics, and I really wanted to accentuate that and just say that from my own experience, when I first started, I was like, I'm not really sure about this. I don't really know how this helps people. And as I continue to work in it, I could see, especially from being with people on a daily basis, to see the improvements from even one day to the next as they continue with treatment. So anyway, if anybody has any questions about my personal experience, you can certainly ask me when the time comes. So you can go into the next slide. Yeah, the learning objective is to have a basic understanding of opioid treatment programs. I feel like that says it all, because there's a lot within opioid treatment programs, and I didn't want to get lost in the little pieces and parts of it. So next slide. Opioid treatment program. We are an opioid treatment is an outpatient program that provides a whole patient approach to recovery with comprehensive treatment services, including pharmacological treatment for opioid use disorder. And again, we have the opportunity and actually the benefit of being able to prescribe methadone, buprenorphine, and naltrexone. These are ordered by a practitioner and administered directly to patients on site by medical staff members in a safe, private environment. Take-home medications, so daily take-home medications can be given to patients after they meet certain qualifications and when the benefits outweigh the risks. We currently do daily dosing with methadone and buprenorphine. We also will prescribe buprenorphine as well. So we have the option to do either, which is really great for us. We are comprised of a multidisciplinary team, licensed physicians, nurse practitioners, physician's assistants, counseling, medical staff, front office. We have a lot of pieces and parts here that work really well together. One of the reasons that I wanted to mention this and feel like it's important is because we do and can see the benefit of daily contacts. We have the ability to do crisis management on a daily basis with people, depending on what's going on with them. the support that's added for some people, and patients will talk about this as well, to come in daily, whether it's at the beginning or whether something starts happening in their lives, and they feel like we're a stable place that they can come and have support that they may not be receiving elsewhere in their lives. It also gives us an opportunity to do ongoing daily assessments with people and build really good rapport with some people. Not everyone loves it, but many people really appreciate it and appreciate the care and concern that our staff shows and gives to people. So next slide. So most people don't know what opioid treatment programs have to go through to get certified. And it takes a lot. It takes a lot to do. The first part on here is that we're governed by the certification of opioid treatment programs, which is 42 CFR Part 8. So interestingly enough, I was working on what to include in this presentation. And as of Friday, February 2nd, there's actually been a new rule for the first time in 20 years, which is a big deal, which is really important to show the growth, I think, of substance use treatment in general, and also specifically opioid use disorder. So I can tell you that there may be some questions that I don't know if they are the same anymore, but I will be very transparent about that when and if anybody has any questions. This new rule will be implemented as of April 2nd, and then has to be compliant with by October 2nd. We are required to be certified through SAMHSA, Idaho Department of Behavioral Health, Idaho Board of Pharmacy, and the DEA. The DEA, as far as being certified through them, we also have to have a significant security system at all of our locations. The safe, we have a really specific type of safe that we can use or have to use, that we're required to use for storing of methadone and our buprenorphine. So anyway, that's part of the whole process. And then being accredited through the international accreditation of CARF. They have a lot, 1,400 plus standards that we're required to meet. And when opioid treatment centers first open, there's a provisional certification, and then CARF comes and reviews every piece and part within the medical, the clinical, and the facility. And then people can be certified for either 1 year or 3 years. And then every 3 years or whatever, however many years it is, they come back and do an additional review, which is good, I think, for us to stay on our toes and up to date. Again, we offer all 3 FDA approved medications, so methadone, buprenorphine, and naltrexone. We provide physical exams, EKGs. We test for HIV, Hep C, syphilis, tuberculosis, and we also do additional lab testing. We offer behavioral therapies, individual and group, case management, mental health services for co-occurring disorder, urine drug testing, and the DEA diversion. We have a DEA diversion plan, which is actually, we here call it just we complete medication callbacks for people. So if they have take-home medication of methadone and Suboxone, we will periodically have them come in the next day, bringing in all of their empty and unopened medication bottles, and we review those for making sure it's still the patient name, correct dates, seals haven't been broken. Like, we go into pretty good detail on that, just because things can be diverted, and we just want to make sure people are as safe as possible. So, and that we're as safe as possible too. Urine drug testing, this is just a side note because there's, we actually have our own in-house lab here, and one of the reasons we really appreciate urine drug testing is because we can test for different things. And we've been testing for carfentanil for years now, and we haven't had any positives until the last couple of months. We've actually had 4 positives for carfentanil, which is, as we all know, very important as far as safety and possibility of overdose and death. And for us to be able to have that conversation directly with those patients, like, hey, this is actually what is coming up in your drug screen, and do you have, like, many people don't know what's actually in what they're using. And so it gives us a really good opportunity to talk to them about it. You can go ahead and move on to the next slide. There is no one-size-fits-all approach to OUD treatment. Many people with OUD benefit from treatment with medication for varying lengths of time, including lifelong treatment. Ongoing outpatient medication treatment for OUD is linked to better retention and outcomes than treatment without medication. Even so, some people stop using opioids on their own. Others recover through support groups or specialty treatment with or without medication. I wanted to bring this up because I think sometimes there's a thought process with a lot of people, and I think this is becoming less and less, which is awesome. But a lot of times people think that they should just, that patients or people should be able to just receive treatment for medication for opioid use disorder and then stop it. Like that it shouldn't be a lifelong treatment. And for some people it is, and they do amazing. We've had patients here who have been stable on buprenorphine and on methadone, have tapered off, done well, and then for whatever reason, life circumstances, they find themselves wanting to use again and start craving substances. And so they find themselves back here, and hopefully they come back before they use, which some people do because they know we're here. And I know there's a lot of providers out there that provide this support and are willing to treat people no matter how often or how long it takes. So next slide. Why include OTPs as a treatment option? Because we can prescribe all 3 FDA-approved medications. These are the only settings within which methadone, a Schedule II opioid receptor agonist, can be legally provided to patients with OUD outside the context of hospital admission or certain other special circumstances. I know there's a lot of thought and beliefs around this, and I just am sticking with what is current. And currently, methadone must be given through opiate treatment programs for OUD. I have this list up here with methadone, buprenorphine, and naltrexone to show that I'm going to leave naltrexone out for the moment, but to show that methadone and buprenorphine are both effective medications, effective in reducing and suppressing opioid cravings and withdrawal. Therapeutic doses will blunt or block euphoric effects of other opioids. Methadone, one of the benefits of methadone is that it can be initiated at any time. Buprenorphine, typically 12 to 72 hours from the time of the last opioid use, or initiating microdosing, which I know is being done more and more often with people, and it's for some people very, very effective. And both of them can be given, and recommended are to be given during pregnancy and while breastfeeding. Currently, there is not any empirical data to indicate which patients will respond better to which OUD medications, which I think is also very key and important to realize. just for some extra information, methadone for OUD began in 1967. Buprenorphine for OUD began in 2002. And naltrexone, the oral form, started in 1984 for blockade effects, and the injectable form in 2010, which I think to me shows that we continue to expand treatment options, and hopefully do whatever is possible to help each individual person. So you can go ahead and go to the next slide. Thank you. Research demonstrates that MOUD can reduce mortality from overdose by up to 59%. Yet few people who may benefit from these medications have immediate and sustained access to them. I just wanted to put this up there because I think it's a really big deal that MOUD can reduce mortality from overdose by up to 59%. And in order to do that, let's utilize any options that are available. And if one doesn't work, let's try the other one, for any and all people that are willing to seek treatment. Next slide. OTPs provide comprehensive interventions, including medications, counseling, and services designed to offer a whole person approach to care and ameliorate social determinants of health that contribute to substance misuse. Numerous studies have demonstrated that treatment with pharmacotherapy and counseling services can reduce overall healthcare costs for patients with OUD. I think this also is very important because reducing costs for patients is important, both personally and for the community and for healthcare in general. So, next slide. I included both of these. First of all, this article, experiences of healthcare and substance use treatment provider-based stigma among patients receiving methadone. It's not just about patients receiving methadone, it's about stigma in regards to substance use treatment with MOUD in particular. Provides a lot of really good information. If you want to check it out. Researchers have increasingly recognized how stigma toward MOUD contributes to inadequate treatment provision. Compared to buprenorphine and naltrexone, methadone is the most highly regulated and stigmatized MOUD. Stigma from treatment and healthcare professionals has a negative impact on treatment access and quality of care. Primary care providers' stigma toward MOUD is associated with lower support for policies intended to increase access to treatment. Even when treatment is available and accessible, providers who stigmatize MOUD may fail to present methadone as a legitimate option. Again, I'm just bringing this up because I think, myself included, in different situations, I get to check myself for my own bias or thought process about what I think works or doesn't work. And to know that there might be options out there for patients, whether it's office-based or opioid treatment programs, to be able to give all of those options to people can be vital to saving lives and actually realizing that it's about the patient and what works for them that's safe and effective as far as treatment goes. Yeah, and especially with our current situation with fentanyl, I think to be able to offer what works for each individual can make a lot of change in our communities, and to be able to collaborate with each other in a way that's like supportive and engaged and wanting to do what's the best option. Because I find if something we're not doing if something we're doing isn't working for the patient, to be able to call someone at another office and say, hey, this this particular person would actually be better off in an office with the way their life is functioning, with their job, with their family, with their travel. And I would really hope that other people would want to do the same thing. And if our care is needed to, yes, exactly, many pathways to recovery. Thank you. So, next slide. I feel like these are the key points I've been talking about. MOUD works, opioid treatment programs work. So let's utilize whatever options work best for the patient. And then the last slide, it's the session resources. And I want to point out tip 63, medications for opioid use disorder from SAMHSA, is so informative. Like if people want details or want to look again and again and again at treatment, this gives great information about all 3 medications. It was just updated in 2021, and we utilize it a lot, and we refer people to it a lot as well. We work with different students from different areas, and we do ask them to not necessarily read the whole thing, but certainly review it. And also the clinical guidance for treating pregnant and parenting women with opioid use disorder. That is also a very, very good resource. All of these are great resources. I just know that those 2 are the ones that we refer to most, in addition to the code of regulations that we get to follow. So as far as the actual slide presentation goes, that is it.
Hey, Cheryl, I've got a couple of questions and comments.
Great, please.
Yeah, so people on this in this session might ask, what's the advantage over, doing MAT out of your clinic, doing Suboxone out of your clinic, and the main advantage is there's just so much more structure provided at a place like Raise the Bottom. There's so much more structure and oversight, and but it's a hassle for patients. I mean, they have to go in every day, versus coming in to your office, periodically every month to 3 months. So I have a couple of things that I was going to ask you to go over the details for. One is, what is your protocol for, how long do people have to come in every day before they can get take homes, and they don't have to come in every day? Because this is a big deal for patients. They have to drive to the clinic before work, and that's what the patients complain about. So that's number one. Number two is, if you could talk a little bit about how this is paid for. Is Medicaid covering it? And also, if you could talk a little bit about if people are getting buprenorphine versus methadone, is that going to cost them more out of their pocket? That's something that comes up a lot. Methadone is much cheaper than buprenorphine, and I understand that at opioid treatment programs, they use about 95% of the patients get methadone versus buprenorphine, and some patients prefer the buprenorphine. So if you could talk a little bit about what your protocols are regarding how many days people have to come in before they can get take homes, maybe talk a little bit about how you handle benzos, and then talk about the cost of things. Who's paying for this, and how does it work when they get buprenorphine? I know that's a lot of questions, but these are things that I think a lot of people are curious about.
Sure, thank you. As far as the protocol for take homes, so I do know that before this new ruling on February 2nd, there was specifically an 8-point criteria that had to be followed. That was actually part of the federal regulations. That has actually changed a little bit. So we will be revising our take-home protocol, and people actually, once they meet certain qualifications and the benefit outweighs the risk, they can actually receive, and I'm just talking about methadone in particular right now. they can actually receive take-homes much more quickly, because previously it depended on what's called a time in treatment date, so how long they've been in treatment, and it took 2 years to get a month's worth of medication or methadone. Now that time in treatment date is no longer going to be part of the criteria for take-homes, so, which is awesome, because it'll cut down that frustration of having to come in every day or once a week for a year or year and a half. I mean, so that 8-point criteria is no longer the same. So really, if someone qualified and they came in and their drug screens were good and they were meeting with their counselor and this assessment and treatment plan, all of the other pieces and parts are done, technically they could get a month's worth of take homes within a few months, or less. So that part has changed significantly. As far as take homes with Suboxone, or buprenorphine, we actually have people, depending on their history or where they're coming from. So we'll start prescriptions or take homes with those people after 30 days of being on buprenorphine, depending on the information that we have. If they're dosing in the clinic and they have 30 days of negative UAs and they're doing well, we'll automatically go up to a week. And again, we can start prescriptions whenever, depending on the person and what's going on with them. So the take-home protocol, we'll be working on our own process as far as that goes. Each opioid treatment program, we have certain policies and procedures that we need to have implemented and in place. And each opioid treatment program gets to determine what that policy is. So take-homes for us may be different than take-homes for BHG, who is the other opioid treatment program in the state of Idaho. As long as we meet the basic criteria, after that, we both get to develop our own process. Did I answer that as far as the take-home part? You're on mute.
Yeah, you did. Yeah. And then if you could, yeah, the other part of the question was, just what do you do with benzos, and then,
Yep.
and then cost, and yeah.
Yeah. As far as payment goes, we actually raise the bottom. And again, I'm at this point, I'm speaking for raise the bottom because other opioid treatment programs have their own protocols. So raise the bottom. We accept cash payment. We take insurance, all insurances, really. I don't know one that we're not taking at this point. For cash pay, the cost difference as far as buprenorphine and methadone, if someone's dose of buprenorphine is greater than 10 milligrams per day, then if, say they're on 12 milligrams, then it would be $12 for the day versus $10. So normally it's $10 a day, whether it's methadone or buprenorphine. But again, if that dose of buprenorphine goes above 10 milligrams, then it's an additional $1 per milligram for raise the bottom. Currently, their Medicaid and Medicare have what are called bundle services, and they cover treatment for both methadone and buprenorphine. All of the other insurances, I'm really not able to speak to the cost of the other insurances because I don't work in the financial billing department piece, but we do accept them. And then as far as our benzo, as far as what we do with benzos, it depends. We have multiple scenarios that we take into account for benzodiazepines. We have actually recently changed our policy on benzodiazepines to keep to retention, safety, like looking at it from multiple aspects. We revisit some of our policies to make sure that they're still safe and appropriate to the circumstances. So if someone comes in and they have a positive for an illicit benzodiazepine, then their methadone dose is reduced by 20%, or methadone is reduced by 20%. And we educate them about the risks of combining benzodiazepines with methadone, and let them know that we'll continue to monitor their drug screens. And this new policy has actually been very effective for us, because before we were a little bit more extreme with our benzo policy as far as the dose reduction goes, and we would lose people, and we lose people as far as treatment goes, or they would be gone for a period of time and then come back not in any better or worse shape, but just not great. And with the 20% reduction, we found a lot of people remain in treatment. They appreciate it, because right now, especially, people are coming up positive for benzodiazepines that have what appears to be no intentional use of that, or aware that benzodiazepine is something that they have in their system. So, which is, I think, really good, again, as far as drug screens go, to be able to educate people. Like, they think they did one thing and another 3 things are coming up in their drug screens. If it's prescribed, it's a different process. We actually reach out to the prescriber, and if the prescriber is willing to continue to prescribe, knowing the person is on methadone or buprenorphine, then we'll go with the prescriber up to a certain point. At this point, if someone's methadone, we won't go above 150 milligrams of methadone if they're currently getting prescribed benzodiazepines. But again, that's with the prescriber aware and willing to continue to prescribe it.
Cheryl, we've got a question from Scott. So Scott, I'm going to go ahead and unmute you, and you can go ahead and ask your question.
Hi there. I don't have quite as many. Thank you for the information, Sharon. Thank you for doing what you do. I think we share a few people in the public. The first thing is I rely on the full disclosure of my patients to let me know that they're on methadone, because it is the only means of notification. And I'm somewhat frustrated that that doesn't show up in the Idaho prescription monitoring program. I can understand, because it's not going through a pharmacy. That's probably where that hang up is. But if they're not telling me, I'm not knowing, and unless I'm testing, which I do, but it is somewhat frustrating to me to not be able to look at that. The other thing is, so I guess this is probably for a pharmacist. If somebody runs into carfentanil and they're using it like fentanyl, how many Narcans does it take to knock a carfentanil off those receptors? Because 9 is the record I've heard so far on some of the people I know that are that have run into things in excess of that. And then the xylazine, is that coming up much around here with you? And what would that show up? That won't show up as a benzo unless it's a horse benzo. So thanks for all that. And
thank you. I'm going to answer the xylazine first. So as far as the xylazine question goes, we actually, one of, again, a benefit of having our own in-house lab is that we can determine what we test for. So we actually have been working on getting xylazine on our testing panel for quite a while. And we actually just went up and running with this in the middle of January. Not the middle, yeah, I'd say about the middle of January. And again, we've been working on it for a while, and we've had positives in Pocatello, positives in Nampa, positives in Boise. So yeah, Aegis, I think, is who Trivium uses as far as their drug screens go, and they're a huge company. They're a huge company that has been, I believe, one of the first to start testing for xylazine. I don't know any smaller local companies that test for xylazine, so we're really lucky and have been able to have conversations again with patients about those results who had no idea. So as far as xylazine goes, we've only been testing a short time, but we definitely have seen it. And I know, and Amy, you can correct me if I'm wrong, but I know working with Dr. Nina, who also works at Trivium, their results from Aegis have produced quite a few positive xylazine results as well in the community. So it's good that we're able to test for it, and that Trivium's doing their testing through Aegis. And I'm sorry, Amy, if I'm speaking out of turn. So
No, you're right. Like we
Okay.
started testing for it because Aegis was like, hey,
yeah,
like this is here. And we had a lot of clients that were saying like they were using other substances, methamphetamine or even fentanyl, and they were like, it's lasting a lot longer, like, it has legs. I don't really understand what's going on. And so we added that to all of our panels, and we were kind of astonished at how many were coming back with it. And like you said, we just use it as a opportunity to educate and talk about the risk of it, and that, Narcan's not going to do anything for xylazine, and just letting clients know what's out there.
thank you. As far as full disclosure, to let people needing to give you full disclosure, to let you know that they are on methadone. This is a big topic for a lot of people when they talk to us. And about how it's not reported to the Board of Pharmacy. That initially was set up that way, and some people would still say this, that it's a lot of it is because of stigma associated with methadone for opioid use disorder. And I know many of us who prescribe buprenorphine, when that some of our patients can still have problems when going to certain pharmacies with certain reactions or feelings of being stigmatized. So that's part of it. There's also a lot so when we're dosing with methadone, we start, and then we're slowly, depending on the order, increasing the methadone dose. And every time we prescribe that, at this point, we would be required to submit that information to the Board of Pharmacy. So that would be a daily submission or every other day submission for some patients for a seriously long period of time, which then could, I look at PMP reports all the time. I look at Board of Pharmacy reports all the time. And so sometimes there's a lot of information there. Then if you think about something being added every 2 days, that's even more information because their medication dose is changing. So that's a big part of it. We have, between all 3 clinics too, we have 900 patients, and if that was something we were required to do, I feel like I'm giving excuses. I just want you to know all the rationale. Like, there's a lot of manpower that it would take to do that. And that requires a lot as well. When we would prefer the manpower to be working with the patients. And we do review Board of Pharmacy reports every month, which is one of the ways that when someone is prescribed a benzodiazepine or some sleep aids or some muscle relaxers, we see who's prescribing that, and we let the patient know, hey, this is what's going to happen. Will you sign this release of information for safety? We can still communicate with these prescribers. So that's one of the reasons why we also have the protocol of sending the letters from Raise the Bottom to other prescribers.
Cheryl, I think a very pertinent question here is, so, provider gets a patient that goes to Raise the Bottom, they're coming into the hospital. How can they get information on what you guys are prescribing? This comes up all the time, right? I mean, I'm assuming you have somebody on call 24/7. They can call you and they can get what they're on, and if you could clarify that for everybody, 'cause that's really important, because sometimes we need to know what they're getting from Raise the Bottom.
Yeah, absolutely. We have after hours phone lines. The phone numbers are listed on if someone were to call Boise and it was after hours, if they listened to the whole message, they would get the after hours phone line. I can also give those numbers to Shannon, who can add them to this. But yeah, we have after hours phone lines for Boise and Nampa, and Pocatello gets routed to Nampa currently. So,
But is there anything restricting you from giving out that information?
Well, it depends on who's asking. So if someone's in the hospital, if someone goes to the hospital and the hospital wants to verify our medication and dosing amount and when we last saw the patient, of course, we're gonna give that information, because we want to collaborate, and it's for the safety of the patient, and they're at the hospital. So as far as other requests, I mean, if it's HIPAA compliant, we'll certainly give the information.
What about just a physician that's seeing the patient at their clinic?
Not necessarily. I mean, it depends on the situation. It depends on the situation. And most of the time, if someone contacts us, we already know that the patient is seeing them. So it's very rare, and I can't remember the last time we haven't given information to a physician contacting us, because we usually have releases of information.
Cheryl, we've got a few questions. It looks like a few people have raised hands, and we've got some questions in the chat too that I want to make sure that we get to. Because we kind of had our case presenter was sick today anyways, we'll skip that part. So we've got about 10 minutes left. And then we'll have Jen present that case in March when she's back. So Neil, I'm going to go ahead and unmute you. And then I know there's a few questions in the chat, and then Eli, if I can push you off just a little bit, we'll do that.
Hey, Cheryl. Neil Reagan, thank you very much for meeting with me through Zoom a couple of weeks ago. I really appreciated the chance to start collaborating more with you. I have a question. Before Raise the Bottom came to Pocatello, I would occasionally get patients from other places who were wanting to, partly because of geography, were wanting to transition from methadone to Suboxone. And that was a little bit tricky with doing that, with them still being able to get methadone, and me, starting microdosing buprenorphine even then. And I'm wondering how often that comes up at your clinic or at Raise the Bottom, people wanting to transition from methadone to Suboxone, and how you all handle it.
Currently it doesn't come up very often. We will definitely transition them from methadone to buprenorphine if that's their request. A lot of times we will attempt to figure out, like, engage with the person and find out what's the reasoning for this, just to make sure that they're educated on all of the pieces and parts of the medications. And also it could be logistical for the patient too. So we want to also support them logistically if there's something like that. We have different ways different options and ways that we can transition people. We're willing to do microdosing as well. Like we will transition people from methadone to Suboxone in whatever way will work for them, as long as we're doing it in a way that will avoid precipitated withdrawal. Sometimes they still don't want to come in daily to do the transition or the microdosing, and so we'll refer them to different health clinics around us who will provide a prescription for microdosing. So
Cheryl, how would you like us to handle it? So we have a patient, we're starting microdosing, they're getting methadone from you guys. How would you like us to work with you during that process?
we've actually been working pretty well with Terry Riley and Full Circle, because they're typically the ones who are doing this. And we've been communicating with the prescribers who are doing that. So releases of information, being able to communicate with each other and knowing what the plan is as far as how the microdosing is going and what the patient is being advised of as far as their methadone dose, and how we can support the process as well.
Great.
Yeah. Did I answer your question, Dr. Reagan? It was
Yes, you
also
did.
very nice. Okay. It was great to meet with you too. Thank you.
You did. Let me jump on and ask one more quick question. You mentioned earlier in your talk about with regard to take-home buprenorphine, and you'll let the patient start basically taking their buprenorphine at home instead of in the clinic when they've had negative UA. What is your definition of negative UA? Is that negative for opiates, or what if they are still using meth?
Negative for illicit substances. Thank you for the clarification.
Okay, thank you.
Yep.
Thank you, Neil. I've got a few questions in the chat, and then we will go from there. So
Can I answer one question I saw in the chat really quick? Because I said, how do we know that they're not going from one clinic to another to another? We actually are required to send something to all opioid treatment programs within 100 miles. In Pocatello, we will occasionally send something to treatment programs a little bit further than 100 miles. So we're actually required to do that to make sure that there's not dual services happening as far as that goes.
Thank you for answering that.
Yeah.
Another question from Carrie. She had a question about methadone-induced sweating. Have you had patients with this? And if so, how was it dealt with?
We have. A lot of people will complain about sweating and while they're taking methadone and also working on stopping illicit opioid use. So when and if they're still using, then we talk to them about the not wanting to cover up anything that might be associated with withdrawal symptoms. There's a lot of conversation with the patient to determine where the sweating's coming from or how, or see if it's possible. If the person is on a maintenance dose and they're not using any illicit opiates, then we prescribe a medication that will typically help with sweating. Most people find it very effective. So we work with the patient, because some patients react really strongly as far as sweating goes, and I can only imagine how that can affect life, especially we have a lot of people who work in the service industry, and that makes a big deal. So we typically prescribe glycopyrrolate.
Great. Okay, Eli, I will finally go to you.
Yeah, so actually she answered my question about them getting methadone from multiple clinics. But I had one other question. So just from my background, we would occasionally, I don't know anymore, but in training, we would manage acute postoperative pain, and people with methadone were always a challenge because of the high tolerance to post-op medications. But typically what we would do is we would take their total methadone dose and split it up 3 times a day. Again, it is a little to Scott's comment. It's very difficult when you have no verification, and it's impossible to get a hold of a clinic when you need to be changing the methadone dosing. But for pain, post-operative pain, we'd take their total dose and split it up 3 times a day or every 8 hours. So that was definitely a challenge. And even though there are the barriers, if there was ever a way to make it available on prescription monitoring program, I think a lot of people love it, even if it's like once a month or something, but that's a separate thing. But the question is, when this is changed, when people change the methadone dosing, how difficult is it, or is it difficult for the patient to just come back after these events are done to the methadone clinic, or is that kind of a barrier?
Pain management, acute pain management is a barrier, period. Like I say barrier period just because it's difficult depending on location to work with the person like you who might be prescribing something for pain because of an injury or an accident. Some people, and again, I think the barrier comes from that stigma with, oh, this person's on methadone and they don't need anything else for pain. It doesn't matter that their arm is shattered in 5 places. It can be really, really difficult. I actually haven't heard that the methadone dose would be split 3 times for something like that. It makes me like, at least it was being thought about, which is great. It's a barrier in general. One of the things that when we work with, because we continue to develop relationships with surgeons around the area, and it's been great because one of the things we say is to maintain the methadone dose as is and prescribe how you would normally prescribe for someone in that scenario. So if you would normally prescribe oxycodone and it would be this amount, or I mean, I'm not a pain management man. I'm not a pain management person. So, but whatever you would typically do, that is the minimum really that we would ask that be done in addition to the methadone dose.
And we would typically get consulted when people are having difficulty, on top of this, and that's when we would adjust the doses and stuff. But then the people are, they get through their hospitalization, and when they come back to the methadone clinic, is that a problem coming back?
Not usually, especially if the person was stable before, because they really want to be stable again. And so it's usually it may take a couple of weeks, but we usually get them back on track pretty quickly, especially if there's someone like you or other people who are willing to work with them and maintain that initial methadone dose, and then being able to taper them off of whatever additional they've been given.
Okay, nice.
Yeah.
Cheryl,
thank
can
you.
at the risk of monopolizing things, can I ask a very related question? So, like with buprenorphine and methadone, the way I understand it is, to control cravings, to control withdrawal, once a day works. But to control pain, they don't last that long for controlling pain, maybe 6 to 8 hours. So you have to give it 3 times a day and sometimes 4 times a day. I had heard in the past that if you guys are treating a patient who has OUD plus pain, that you're not really allowed to dose it that frequently. Is that true, that you're limited as far as how frequently you can dose methadone during the day?
We are limited. And the most we typically do is twice a day with split dosing. But again, that's if they meet certain qualifications and it doesn't have anything to do with pain. But if someone's on like palliative care or there's something else going on with the patient, we've also collaborated with providers, and we can do up to 3 times a day. That would be an extenuating circumstance that we get to have a lot of documentation for and collaboration with whoever the physician is and why the request is being made.
Well, that's